welcome to the Research Works podcast, brought to you in association with Curtin University and the Healthy Strides Foundation. Your hosts are Dr. Dana Poole and Dr. Ashley Thornton, and together we will interview world-leading researchers in the area of child health to support your practice in being more evidence-based.
Today we're reviewing an article published in 2020 in Developmental Medicine and Child Neurology titled Autism and Attention Deficit Hyperactivity Disorder in Children with Cerebral Palsy, High Prevalence Rates in a Population-Based Study. To discuss this paper and the implications it has on our practice, we have the one and only Dr. Kate Langdon joining us in the studio today. Hello, Kate.
Hello.
Welcome.
We're mixing things up a bit today. But before we get into the details of the paper and all the things that we are so excited and keen to talk about, because it is a really interesting topic, we thought we would just go around the room and do a little icebreaker. And that one for today is, what is your favourite movie quote?
Mine isn't particularly profound, but it's something I repeat repeatedly from Kindergarten Cop. Are you ready? Who is your daddy and what does he do?
And for me, the only thing that came into my head was, I think, the first line of Out of Africa, which was, I had a farm in Africa in the Ngong Hills. That's it.
Delivered beautifully, I might add.
Nicely done, Kate. Ash, I can't wait for yours.
Well, mine's even more highbrow than that. It's from Anchorman, and it's 60% of the time, it works every time. I could also give you the whole script of Grease, but I won't. I'll save that for another time.
Okay,
yeah.
Next time indeed.
Yeah. We have Dr. Kate Langdon back with us today, and thank you, Kate, for joining us to talk about this really interesting paper. Just as a bit of background, Dr. Kate Langdon is a paediatrician and specialist in paediatric rehabilitation medicine in the Kids Rehab Department at Perth Children's Hospital. We know that Dr. Langdon has a wealth of experience, and her insights, particularly with regards to diagnosis, management and the medical perspective, we think are really going to help us draw out some of the key takeaway messages from this paper today.
You can definitely hear the excitement in our voice with this one, because there's something about this paper that's really drawn us toward it. And I think when you look at our clinical practice, you know, we all have seen this sort of scenario, and finally we get to talk about it and understand it. This is actually the third paper in a series of papers in a project that aims to establish accurate prevalence rates of autism and ADHD in children with cerebral palsy. Well, let's go into the abstract and describe what actually is in this paper. So the target population was actually from the register, the CP register in Western Sweden. So it involved 200 children born between 1999 and 2006. So there are 109 males and 91 females with a median age of 14 years. Now, with regards to the intervention and the comparator, it was all about using comprehensive screening procedures with standardized neuropsychiatric clinical assessments specific to autism, ADHD, as well as intellectual cognitive testing. Now, the outcome. Of the 200 children, 45% were diagnosed with autism, ADHD, or both. 30% were diagnosed with autism in children with cerebral palsy, and 2/3 of children had autism, ADHD, and or intellectual disability. Now, what was interesting here was autism was more common in children who were born preterm, and gross motor function was not necessarily associated with autism. The ADHD prevalence rate was actually quite low in children with severe motor impairment. There is so much to talk about here.
Absolutely. And Kate, we were just talking before we got started about CP registers, and you had a really interesting fact that kind of linked this paper to us over here in WA. Can you talk a bit about that?
Yes, the Western Sweden CP register is one of two oldest CP registers in the world, and I can't remember whether the one in WA is older or younger than Western Sweden, but it's they're close. So it is a very old, well-established CP register able to do population-based research like this.
And that was something when we were talking to Professor Iona Novak when she was on the podcast earlier in the season. She highlighted looking at registers as a real obvious strength, you know, in terms of future research and being able to draw on those registers for this population-based research.
And it's of critical importance with this paper.
Mm-hmm. Absolutely.
And I think the reason why we're so just taken by this paper is the actual prevalence rate, which is it's higher than one would expect, I suppose. And Kate, before we go too much further into the incidence rate, I think we need to understand a little bit more about what ADHD is, how it comes to being diagnosed, and one of the measures they use for this, which I've heard of before but I've never used, obviously, is the Diagnostic and Statistical Manual of Mental Disorders 5th edition, or the DSM-5. Kate, can you tell us a little bit more about what this measure is and why it's used?
I can. The DSM-5 is the fifth in a series of classification systems initiated by the American Psychiatric Association that really classifies different phenotypes and different mental disorders into groups for the purposes of research, for the purposes of providing clinical services, and also to understand them. They've been revised and changed many, many times over the years. And I think if we looked at the original DSM classification systems that came out before the Second World War, they look vastly different. And there's also a cultural overlay with conditions that are no longer seen as mental disorders kind of going by the wayside and other things entering in and replacing them. So I think they're very organic representation of how mental disorders are viewed in our society, but they have there's a fundamental need, I think, while we don't necessarily understand the organic basis for disease, to at least have some structural way of conceiving of them, to research them, understand them, and to also build services to support people who have them.
Sure. So we would use that measure in the diagnosis of ADHD. Is that what the process would be?
Yes, and particularly in the case for research, the DSM-5 classification is quite clear for ADHD and also autism spectrum disorders, where that you need to have had symptoms for more than 6 months, and you need a persistent pattern of inattention, hyperactivity, and impulsivity. And they go through the kinds of actually pretty good examples to give you an idea of whether a child should have a diagnosis of ADHD. So they've failed to give close attention to details, really have difficulties with sustained attention, doesn't seem to listen when spoken to, can't follow through on instructions, have difficulty organising tasks, dislikes, reluctant to engage that require sustained attention, loses things they need to get things done, very distracted by extraneous stimulation or stimuli, forgetful in daily activities. But there's also a whole lot of physical manifestations of hyperactivity and impulsivity, which is particularly important when you think of this paper, that they often fidget or tap hands or feet or squirm in seat. So you need to be able to fidget and tap your hands and squirm in your seat to have the diagnosis.
Right.
Leaves your seat in situations when remaining seated is expected. So if you want to leave your seat but you can't leave your seat, you can't have that. Then they run about or climb in situations when that might be inappropriate, unable to play or engage in leisure activities quietly, often on the go or driven by a motor, talk excessively, blurt out an answer before a question has been completed, difficulty waiting his or her turn, and interrupts or intrudes on others. So many of those latter examples would be very hard for someone who has difficulties with language and is reliant on wheeled mobility to actually demonstrate, which I think is kind of alluded to in the paper. But, it's not because the diagnostic tool is problematic. It's just you have to describe it in some way.
Yeah.
And I think most people speaking to people with language difficulties are more manifesting that intrusion and interruption than the poor person is trying to get their stuff out.
Yeah, absolutely. So even when you're describing that, I can, in my head, start to think about all the children that I've worked with where, people respond differently to different interventions. We've spoken about that before in the podcast, and you kind of go, well, is that because we haven't implemented the tools that you would use for someone who has autism and ADHD? And with the prevalence rates that are reported here, it's most likely that's a contributing factor.
Absolutely.
I would totally agree. And I think these astonishing numbers in this paper are really important because I think families like you, clinicians and physiotherapists and therapy providers, are probably seeing these features wondering whether it's them, whether they're, there's all sorts of explanations for it. But actually having a way and a framework and, if necessary, a label to describe really big problems in their child's ability to make friends, socialise at school, learn at school, pay attention, tolerate disruptions in their daily routine.
Yes.
Just to have some way of gauging that those very real problems they're encountering in their child come back at them with a validation that, yes, you're not imagining this.
That's right.
This is actually very common. Would be very helpful, and would be helpful, I think, probably early in a child's life rather than being finally uncovered at the age of 14 or 17 as it is now. There's such a focus on early detection in terms of the motor aspects of cerebral palsy, but I guess our task now is to be a bit more proactive with some of these other factors, particularly given 2/3 of children either have ADHD, autism, or an intellectual disability. That's a very high number.
Yeah, it is. And given that we are at this place now where we are detecting cerebral palsy very early on, this needs to be part of something that we're considering, because we keep talking about the fact that cerebral palsy, yes, it's the most common physical disability in childhood. And we're trying to say, look, focus less on the motor because there are other things to focus on. And this just really pulls us in the direction to go, we really need to look at things beyond motor right now.
We are so thrilled to have the opportunity to have a quick chat with the lead author of this incredible article. Dr. Magnus Påhlman is a paediatric neurologist from the Gilberg Neuropsychiatry Centre, University of Gothenburg. His PhD, titled Autism and ADHD in Children with Cerebral Palsy, clearly highlights his expertise in this area, and we are so grateful for this work because of the impact that it has on our clinical practice. Thank you, Magnus, for making time for us in your busy schedule. So, Magnus, why was this work important to do? What prompted you to do this study and write up this paper?
Well, I am a pediatric neurologist working mainly with children with cerebral palsy. So this is my daily clinical work.
Yes.
I've met this problem in my clinician as a clinician.
Yes.
Actually, from when I was trained to be a pediatric neurologist, I started working at an outpatient department and was often reflecting about those problems, usually coming up in the end of the visit from the family. They raised question about autism, hyperactivity, inattention problems. So actually it's where it started, and I realized there was not much information when I looked after.
Wow.
And I realized also that children with cerebral palsy, their main problem might not be the motor disorder, but other problems that might be intellectual disability, vision, hearing, but also autism was what I was reflecting about quite a lot.
Wow, that's so significant, the fact that you saw that in your clinical practice and went ahead to try to answer that question to find out more. That's amazing.
Yeah. and I think also that there's been some research showing that early detection of autism as well as ADHD might lead to a better function, participation, giving the right support at the right time, and maybe a better prognosis later in life.
Yeah, that's so significant. And I'm really curious because what's really stood out in this paper, because, you made me reflect on my practice and who I see on a day-to-day basis as well. And I'm quite curious about this high prevalence of autism and ADHD in children with cerebral palsy. Were you surprised by this number?
If you had asked me at the starting point, I would have been surprised by the high number.
Yeah.
But as time went and I got more information, deepening, understanding more, I realized this is not, I'm not surprised any longer.
Yeah.
I was actually, this is the third article of 3 in some sort of 3-stage rocket. And in the first, we really scrutinized all the records to see what had been identified. And we got numbers, 18% autism, 21% ADHD, which was high actually already then.
Yeah.
So I'm not surprised after that it was actually 50% higher than what we had from the beginning.
Wow.
Yeah.
But we have a tradition in Western Sweden from the Gillberg Neuropsychiatry Center with knowledge about autism and ADHD, and several of us pediatric neurologists have been trained at that center. So I think it's about putting on the right glasses to actually see what you see, or realize what you see.
Yeah. And
that's so good.
And Magnus, given that we do have these high prevalence rates of autism and ADHD in children with CP, where do you see the direction of your research next? And what implications do you think that it might have for clinical practice as well?
Yeah. That's two different questions.
Yeah, two big questions. Why don't we start with research first?
Now we are looking at the neuroradiology findings in these children to relate autism and ADHD and see if there are any patterns in the underlying brain lesion or brain disturbance.
Wow.
There's a paper coming soon, I hope.
Oh, that's exciting.
And we are trying to work together with a neuroradiologist to actually digger in what the brain lesion might tell you. It might be a clinical value in that, prognostic value.
Yes.
And
in the next, there's some sort of mix in research and clinical work. The screening questionnaire we had was large. There were nearly 300 items for parents to complete, and we are trying to boil it down to something more clinically useful. Because I think in clinical practice, you should have a high awareness of signs of autism and ADHD in small children, and a low threshold for further neuropsychiatric assessment. But I think as autism and ADHD was present in 45% in our population, which is it's population-based, and that is in the same range as intellectual disability and epilepsy. And in Sweden, at least, we strongly recommend all children to be assessed cognitive before school start.
Yes.
And I think to add some sort of screening evaluation at that age for all children, and if indicated and necessary, you should go further with a broader assessment.
Absolutely.
That was what I think, we've really just taken from this paper is, as clinicians and therapists, we often work with all these children quite early on when they have a diagnosis of cerebral palsy, and what you've spoken about in terms of screening and identifying this early is so very important. Now, is there anything that hasn't quite made it onto this paper that you could sort of enlighten us on? I know always articles have their strict word counts and there's things you want to be able to put in there. Was there anything here that you wish you could put into the article?
Yes, we have much more data in this.
Yes.
But we are just presenting the gross motor function.
Sure.
We have fine motor function to that there are interesting things there as well.
Yeah.
Communication, we are really thinking about that because we had some data of the CFCS, the communication function classification system, but it was not complete. So we didn't try to use that because we actually had the population-based approach with all data to analyze. So
Oh, there's a lot there isn't
there are more things to do.
Yeah. It sounds like a huge body of work. And yeah, we really look forward to reading the next papers that come out of it.
Yes, and we will definitely be asking you to come back on again, because I think there's so much more there.
I talked to 256 parents about this study and encouraged them to participate.
Yeah.
And it was often like lifting a lid and to get their story about their children. In many times they had to fight for neuropsychiatric assessment because they were told it's CP, it's not autism.
Yeah, yeah.
And like you say, the focus is...
The rule is rather both rather than just one diagnosis in this field of neurodevelopmental disorders.
Yeah.
A single child should have their own sort of function profile identified early.
Yes.
For the right support at the right time.
Yes. Yeah.
Because I think that timing is also...
Yeah. Can I ask just quickly, with a screening tool, you said the original screening tool that you did use was 300 items, and you're looking at the next stage of that. What are you sort of hoping to come out of that? Are you hoping that it's something that health practitioners can use as an initial screen to then encourage a more formal neuropsychiatric assessment? Is that what you're thinking?
Yes.
Okay.
Maybe we could just use 20 or 30 items. That might be enough to just a quick screening to see which children to assess further.
Yeah. That's so important, because often, as you said earlier, the focus is around gross motor function, and there isn't necessarily, I know, within our tertiary hospital here, it's a mobility clinic that these children come to. So the focus is on their gross motor function, and they might have a 15-minute appointment.
Yes.
And so a really quick checklist that could be included in that would be so valuable. And I know it had really good uptake.
Yeah, for sure. And I how you described before, it's like lifting the lid. It's the part of the conversation towards the end, and you go, whoa, there's actually so much more that the families are living with that we haven't been able to uncover. Yeah.
Yes. And just asking the question might open up things that they think they are seen. We understand part of what they are in.
Yeah. Yeah. It's just a bit more of an insight.
So I was a bit afraid in the beginning, talking to parents with children with cerebral palsy and asking for autism, that they might be, no, they have not. But it was nearly the opposite.
Right.
They told, this is important. Maybe my child does not have autism, but I know other with CP that certainly has.
And sometimes I suppose it's a suspicion that there's something that they know isn't quite there, but they don't know what to do about it, and no one's asked them, so they don't say anything.
Yeah. And if they get no, it's not necessary to look at this.
Yeah.
I think they will get confused.
Yeah. Yep. What a great way that you've done it through this population-based study. I know that we're talking about the register in Western Sweden, how amazing it is in terms of the wealth of data.
Yeah.
What a great way to use this, in terms of a population-based study to understand the prevalence.
Yeah.
So, yeah.
And combining with the neuropsychiatry expertise here in Gothenburg.
Yes.
That was my crossing.
No, that's absolutely amazing. Look, I feel like we could talk to you for a very long time.
And we will when your next paper comes out, I think.
Let's definitely stay in touch, and we'll help spread the word about this through this. And I know that this episode will be something that clinicians will have with great interest, because it's definitely captured my thoughts for the last few weeks now. Well, thank you so much for your time. It's been incredible to have you here. I know you're very busy, and it's nice to be able to speak to wonderful researchers like you all the way across the world for us, all the way in Sweden. So thank you so much.
Thank you, and you're welcome to get in contact again. And everyone that hear this may feel free to contact me.
Oh, that's very generous. Thank you so much.
Thank you, Magnus.
That's really key piece, isn't it? providing the right types of therapy.
Yes.
Whether they be motor or more behavioural-based therapies, and also an education program that really matches the child's needs in the school.
Kate, can I ask you, we spoke a little bit earlier about this, and I think it's really worthwhile trying to just describe what you would see with a child who might be in a wheelchair, for example, coming into clinic or coming into therapy or going to school. What would it look like for them to have a diagnosis of autism or ADHD that hasn't been diagnosed just yet? What would be some of the features you would see?
Sometimes it's a parental burnout, actually, that the child is doing what the child does. They're often quite fearful of being in the clinical room, and often that manifests, particularly autism, as anxiety. And sometimes probing parents and finding out whether their child has autistic features is something that you do offline rather than online.
Sure.
Many of the services we run are directed towards mobility and addressing the manifold issues that need to be addressed there. But when you go offline, as I tend to do in clinic, my poor physios will attest to that, you find out all sorts of things. And parents, one of the things that I've really noticed that really rang true when I was reading the Autism Spectrum Disorder diagnostic criteria, particularly the restricted repetitive patterns of behaviour, this bit, the insistence on sameness, inflexible adherence to routines or ritualised patterns of verbal or non-verbal behaviour. Example, extreme distress at small changes, difficulty with transitions, rigid thinking patterns, greeting rituals, needing to take same route or eat same food every day. How that seems to manifest for the families that I see is that if they want to go on a family outing, for example, most of the parents will think in advance and plan for every possible eventuality that might occur and prepare their child for those unexpected occurrences. But there's always something that they can't foretell, and that may result in an absolute meltdown of their child and then an abandonment of the said journey, and they all have to go home. So I think that in terms of family functioning, this is so key and may be more important to engage with than the motor difficulties, which can be overcome by wheeled mobility or whatever you need. But when a child is extremely distressed and you can't get them back again, often you have to just abandon ship. And so it really breaks down family relationships, interpersonal relationships between the siblings, parents, children. You know, it's profound.
Yeah. And is it a matter of just being aware of that as a clinician? Because, I mean, one of the things they touched on in this paper is that it's quite difficult to actually diagnose the presence of ADHD or autism, particularly in our higher GMFCS levels, because as you talked through when you were reading the diagnostic criteria, a lot of those things we can't actually tease out for those children because they are wheelchair bound and you know, they don't have the communication skills necessarily to be able to highlight some of those issues. So how do we, I suppose, come at that from a clinical perspective?
I think it's really difficult to diagnose it, but I don't think it probably matters, and the ADHD matters less because jumping up and down out of your seat is just a real problem again with social relationships where, you know, to good communication requires someone to be very present. And if someone's always jumping up and down or interrupting or butting in with something they want to say or just clearly unable to pay attention to what you're doing, communication and friendship building's out of the way. So I think that as long as you're aware of the end problem and how that, which is difficulty with social relationships, difficult with education, doesn't matter what the labels look like. So I wouldn't sweat it too much that ADHD is hard to diagnose in children with higher fine and gross motor impairments. I think it's just a sort of take it.
Yeah, and the outcome is still frustration because they're unable to I guess to express themselves in that kind of way. All the routine's been disrupted. And it is, like you said, Ash, being aware of that and working that into our therapy programs or within education. And I think what this highlights is the focus of needing to be, as therapists, as clinicians, as educators, to take that step back and think about all the strategies and the new skills we actually need to learn and gain. Because if we're saying 2/3 have a diagnosis of either autism, ADHD, or intellectual disability, we're saying 1/3 don't have that diagnosis. That's a very small portion.
Minority.
That is. Yeah, that's right. So what do we do and how do we do it? And I think we really just need to go, we need to train up.
Add to your repertoire.
Yeah, that's right.
That is exactly what I thought.
Now, there were some things that were highlighted in this paper with regards to particularly being with autism, being extremely preterm, which is defined as being less than 27 weeks. Let's talk about that a little bit, because I thought that really came out. And when you think about cerebral palsy and, where does that fall in? Kate?
Well, I was very happy that you highlighted you were going to ask me this because I guess it's worthwhile looking at some of the data. So at the moment, 40% of children with cerebral palsy are born preterm. And the data from the references in this paper showed that 30% of babies born preterm have autism spectrum disorders compared to 1% of full-term births, which was, quite an astonishing figure. And but I guess I was a little heartened that the trend in cerebral palsy is to a lesser degree of severity in terms of cerebral palsy. So perhaps a later cohort than this, which ends at 2006, as we've had a change in the prevalence of cerebral palsy, perhaps we're actually seeing a shift in the associated impairments because we are moving to more children who are GMSS level 1, although there's a slight increase in GMSS level 5 as well. So I think this actual study probably needs to be completely replicated holus bolus with a different whole population-based sample.
Sure.
But it doesn't, you can't escape from the fact that as far as a red flag goes, preterm babies need to be given an even more clear sort of screening so that you don't miss them. I mean, that's a key.
What would that look like? I mean, there's the real structured assessments that you can do as were listed in here, but they also did screening, which was their first part, which is what they did in their paper. That was actually pretty accurate. Can we talk a little bit about the screenings? I feel like that's the first great step for us to take here.
That was a different paper, but we obviously all need to go and check that. And this paper was to really verify and validate how helpful that screening process had been, and the specificity and sensitivity of both the screening tools weren't too bad. I think the specificity for ADHD was a little bit lower, but it was pretty good for autism. Yeah. So the tools that they used are probably reasonable. I think it's we will need to do some fancy footwork around the diagnosis of autism spectrum disorders here, because you can see that it's quite labour intensive with a team approach, and there's a wait list for that service. A screening tool is helpful, but obviously doesn't confirm the diagnosis.
Sure.
But in order to kind of provide supports, even understanding that a child you're thinking about autism,
that's right,
might be helpful in approaching them in therapeutic settings and in educational settings, and it should influence their NDIS plan as well.
Absolutely.
So under what circumstances would you refer for more formal assessment?
We're trying to work that out as we speak. What is it that makes us act to refer on to see a neuropsychologist? And we don't have a checklist at the moment, but that would be a good way of going about it.
Yeah.
But the other thing to do would be wonder whether the MChat, one of the screening tools used in some of the preterm autism research, would be useful in our population.
What's the MChat?
Oh, I had to write it down.
Yes.
The modified checklist for autism in toddlers. So it's used in babies around 18 months.
Who can carry that out? Who can?
I don't know.
Nutrition? Oh, okay.
No, I don't know. I really, it was all news to me. But of course I had to go down an alley to go and think.
A bit of a rabbit hole.
What do we do now?
And I like the way that we're sort of thinking here already, because we're sort of going, well, there is a formal diagnosis, and a lot of what we're seeing are from, parent report. That's a big part of it, because like we described before, Kate, parents are already adapting because they know their child. There's this behavior that they've already adapted to such a point where they've kind of normalized it as part of their life. But if we actually as clinicians take the time to talk that part of it through and what their day looks like, we can already go, oh, hang on a minute, knowing these statistics, let's not scare them, but let's go, okay, let's look at some things we can put into place. Do we talk about self-regulation and co-regulation? Are we already starting to talk about using communication cards or daily timetables? There's simple things we can put into place quite early on as we navigate through the system, and then hopefully getting some support for those behaviour supports in NDIS.
Yeah.
Yeah. So I think those things start quite early. I think there's a lot to look at here, and I think this is just a great piece for us to start thinking about it, putting things into place. And if you see training coming up with regards to autism, ADHD, I would say, put your hand up for it and go for it. Yeah.
Put that in your toolbox.
Yeah, I think so. There's a few more things to add there. Oh, final question actually. Kate, all I've really heard of with regards to ADHD is you do hear about people using medication. Do you have any insights into what that is and how this would apply in this situation?
Yes. I mean, I did think of that and kind of sighed in the way that I just did because so many children with cerebral palsy, are on medication for one reason or another, or have many medical issues to worry about. I think it's important to get the diagnosis right, because one of the side effects of stimulant medication can be emotional lability. And if they have a co-occurring autism, then anxiety is going to be a feature. So you really need to actually think through what medicine you're offering and what the child's inattention may be about, whether it's in fact stimulation overload and they're just kind of freaking out rather than not paying attention. So yes, you can apply or use stimulant medication in all its forms for a child with CP, but you need to have decent follow-up to make sure that it actually is beneficial, given the nutritional problems that kids with CP have, the possibility that they are actually emotional lability is not something you want to make worse. There's also side effects of tics. So yes, it's effective and can work, but it's not like, yay.
Yeah.
It may be more about an educational plan where children's, you provide an environment where you reduce excessive stimulation and stimuli and allow the child to focus and also pitch the information they're getting at the right level. I don't know whether some of the children's inattention is about not understanding cognitively what is going on. And if 51% had an intellectual disability, maybe they just didn't have a clue.
Yeah. It's hard to tease that out.
Yep.
Yeah. So, Kate, this might be a potentially curly question to finish off on, but given after reading this paper, what we understand now about prevalence rates of intellectual disability, autism, ADHD and cerebral palsy population, what would, I suppose, be your practical take-home message for clinicians?
I think that the toolkit suggestion of yours, Dana, is really the answer here, that we need to be much more receptive for these presentations when they're in our rooms and recognise the really important impact that they have. They allude to it in the paper, saying that some of the manifestations and associations of CP have much more of an effect personally and on the family than the motor concerns. and I think we need to just skill up in order to be able to address them and have services that are a bit more responsive to that.
And perhaps delivering those motor-based interventions in a way that's respectful of the potential behavioural complications that might come as a result of these co-occurring conditions.
Yes.
Yeah,
wholeheartedly.
We should be putting them in when we're looking at research and describing the population that we're working with. That needs to be in there because that will help us to understand who's responding and who's not, and how do we modify things accordingly. Yeah, there's a lot to that.
Is it so true? I think you are more mindful of that. I think you've looked at that, the influence on therapy, whereas for me it was, oh my God, I'm seeing them in the hospital, maybe I haven't missed them all,
Yeah.
So yes, that's a beautiful reflection, isn't it, on the therapy, the population that you're doing all research on. You just need to know who is in your cohort.
Yep, let's describe them properly. Yeah.
We've all got some upskilling to do.
I think we do. Well, thank you so much, Kate. We're actually going to go into our next segment now called Tell It to Ed. Now, as we all know, Ed is our producer and he doesn't have much of a background in child health. And I'm just changing that description now because I do think he's knowing more and more. So he's definitely improving his skill base on that. And that's a testament to people on the show. So, Kate, here's an opportunity just to describe to Ed a little bit about what we've been talking about, and he'll have an opportunity to ask you some questions as well. Take it away.
Hi, Ed. I woke up this morning and I opened this book and I found this paper and I realised that a condition I've been looking after for more years than I care to mention now has this whole different clinical presentation, including high overlapping with ADHD and autism, and which is going to change everything we do and in every way we do it. And it's really worrying me that I haven't got on top of that. Can you help me?
I don't think I've learned quite enough over the course of the series.
Maybe next episode.
Yeah, maybe so.
Sure.
Thanks,
let me study up and I'll get back to you in 7 days.
Well, Ed, do you have any questions based on what we've been talking about today?
Oh, look, the talk's been incredibly eye-opening. I'm staggered by the 2/3 statistic. I don't think I've ever heard anything like that before, certainly not from watching mainstream news and radio and the like. Is there a particular reason as to why this number is now so high? Is the diagnosis now so much better than it was years ago, or is there a particular reason as to why we're looking at that 2/3 and above number?
Well, I think there is a contribution made by the number of pretermers, and that's part of it. And in the background, there is an increasing rate of autism. So I think there is a kind of an effect from that. But I guess cerebral palsy is a neurodevelopmental problem. There is a brain injury. So I think there's overlap with phenotypes as well. And it was good to know that there was no real relationship with MRI findings. It's not that clear cut. That would make it overly simplified, but I think there is a bit more light being shone.
Thank you very much for that. Well, thank you, Kate, in particular, for being here and answering our questions, because there was very little that I feel like I knew about.
We had a lot of them.
We had. So thank you so much for being here for that. And for everyone who wants to get some of the notes for this or access to the paper in terms of where to find it, you can head to our website, researchworks.net. And of course, as per usual, if you want this recorded as part of your CPD, there's a form on our website that you can fill out as well, some reflection notes too.
Next week, we're going to talk to Dr. Belinda McLean, who is the lead postdoc for a project called Discovering the Sense of Touch and the implications that sensation impairments have for children with cerebral palsy. So another interesting one to stay tuned for. Thank you so much for your time today, Kate. We really appreciate it.
My pleasure. Thank you for the invitation.
Thank you very much. Catch you guys next time. Bye.
Bye.